بسم الله الرحمن الرحيم الحمد لله رب العالمين صلى الله وسلم وبارك على نبينا محمد. Greeting to you all. Today inshallah ta'ala I will be talking about pathophysiology of cyanotic congenital heart disease. I am Dr. Jameel Abdulaziz Ata. I'm a consultant pediatric cardiologist at King Abdulaziz University Hospital, Jeddah, Saudi Arabia. So to start with, what is cyanosis? Cyanosis is basically the blue discoloration we see on patients. So cyanosis is being blue. And why would we become blue? It's mainly because our hemoglobin, which carries our oxygen, becomes deoxygenated. So we call it deoxyhemoglobin. And if we carry too much deoxyhemoglobin in our blood, we will become cyanotic. From cardiac point of view, cyanosis comes from two major issues or two major problems that happens to the child or to the infant, and then he or she would get cyanotic. So the first thing is the major cause of cyanosis, which is the right to left shunt. Any blood from the right side of the heart is a blood which is deoxygenated. We know the right side of the heart is composed of the right atrium and the right ventricle, and both receive the blood from the inferior vena cava and the superior vena cava. And I will draw that when I come to specific lesions when I talk about them. Any blood going from the right side to the left side, which is supposed to be receiving the oxygenated blood from the lung, which is the left atrium and the left ventricle, that will cause the blood on the left side to be mixed with the deoxygenated blood, and hence the patient will become cyanotic. So mixing, or right to left mixing, is a major or the major cause of cyanosis from cardiac lesions. In addition to that, if one would become more cyanotic, if this right to left lesion is added to by decreased pulmonary blood flow. If we have decreased pulmonary blood flow, that means the lungs are not receiving the full cardiac output they should receive, then that would also lead to less oxygenated blood coming to the left side, adding to the problem and making the person more cyanotic. So this is the basics of being cyanotic. So how much hemoglobin do we need to become cyanotic? Obviously, if you are too much anemic, let's say if a baby has a hemoglobin of 7 grams per deciliter, then this baby, because of severe anemia, severe pallor, may not show the cyanosis well. We know that for us to show cyanosis, we need at least 5 grams of hemoglobin to become deoxyhemoglobin. Imagine somebody with a hemoglobin of 7, how he or she could have 5 out of 7 and living only on 2, that will not be livable. So these babies will not show cyanosis because of severe pallor. And that's an important caveat in clinical examination of babies with cyanosis. We human beings can detect somebody with cyanosis, calling them blue, if what we call the oxygen saturation by pulse oximetry, and pulse oximetry is a methodology by which we measure oxygen saturation, which is widely known today, and actually it should be and is part of the vital signs of any patient coming to a medical facility. So for cyanosis, for us to catch it by the eye, the person has to be at least 85 or above, below 85, we can detect cyanosis. So if a person comes, the normal saturation for us is 95 to 100%. We call it the SpO2. Okay, so that's your normal saturation. When can we detect cyanosis clinically? Before anything else, before any investigations, if the person is 92, our eyes cannot detect it. 90 cannot detect it. We start detecting cyanosis by our eyes when the person has a saturation of 85%, which tells you how far it is from 100 to 85. 15% less, then we start clinically diagnosing it, which means clearly we can miss many cyanotic children, many cyanotic infants, many cyanotic persons who come to our clinic if we do not do pulse oximetry. Obviously, the cardiologist trained eye may pick up cyanosis at slightly higher than 85, maybe 88, 90, but definitely we are all going to be deceived if the saturation is 92. And we have to know that even a saturation of 94, which is very close to 95%, is not a normal saturation. We still call that person a cyanotic child or a cyanotic person. So when we talk about cyanotic congenital heart disease, there are many classifications for such disease. And just before that, I would just want to add that cyanosis can come from non-cardiac reasons, as we all know. If we have severe lung disease, if we have methemoglobinemia, and other causes. But here today, our talk is really concentrated on cyanotic congenital heart disease. We can divide cyanotic congenital heart disease into many classifications. One of the best is to divide it based on amount of pulmonary blood flow. So if we say cyanotic congenital heart disease, CCHD, cyanotic congenital heart disease, one of the best ways of dividing this disease is actually to talk about, is this cyanotic congenital heart disease with increased pulmonary blood flow, or is it with decreased pulmonary blood flow? Such a classification is quite good in making us understand such a disease. And we have common diseases that fall under increased pulmonary blood flow, and they are cyanotic. And we have also other common diseases with decreased pulmonary blood flow that have or that fall under cyanotic congenital heart disease. And by the way, there are ones who do not fall under any of them, but they share the same origin, which is cyanotic heart disease. What can we think of? Common diseases in each arm. In increased pulmonary blood flow, what can you think with me? Who has a right to left shunt but do not look that much blue because they have a lot of pulmonary blood flow? And this is one difference between the two groups, that with increased pulmonary blood flow, the SpO2 tends to be higher. Higher meaning it's anything between 88 to 94%. And when we talk about decreased pulmonary blood flow, usually the saturation there is less than 88%. Sometimes even much less than that. One important factor that differentiate both, or is common in one and not common in the other one, usually in patients with increased pulmonary blood flow, there is no pulmonary flow restriction. or what we can translate into there is no pulmonary valve stenosis. So here there is no PS, while on the other side there is usually valvar pulmonary stenosis, or PS as we would abbreviate in our talk. طيب, so let me just write down for you some of the common, and then we will go into how we describe them and how we talk about them. So with increased pulmonary blood flow, there is one famous lesion which we call total anomalous pulmonary venous connection or drainage. This is one common disease that falls under the increased pulmonary blood flow, and so many other diseases. And on the other side, there is tetralogy of Fallot, or TOF. I hope the color is clear and you could see it. The green did not really show the best. So I will be spending more time now on talking about total anomalous pulmonary venous drainage as an example for cyanotic heart disease with increased pulmonary blood flow, and on tetralogy of Fallot as an example of decreased pulmonary blood flow in cyanotic congenital heart disease. So just to recap, we are talking today about cyanotic congenital heart disease pathophysiology. I'm not talking about the disease clinically in depth, but I'm really talking about the pathophysiology. And as we understand pathophysiology quite well, we can definitely treat and understand the disease much better than if we don't. So let's take our first example, which was total anomalous pulmonary venous drainage, as an example of cyanotic congenital heart disease with, can I hear it from you? I know you're not there, but I'm going to say it, with increased pulmonary blood flow. We have agreed that we will be talking about total anomalous pulmonary venous drainage. So I will just remind you quickly about the anatomy of the heart. So if we draw a normal heart would look like this: two ventricles, two atria, and then the muscle, the interventricular septum, the other muscle, and these are the atria which are divided by the interatrial septum. This is the left ventricle, and this is the right ventricle. This is the left atrium, and this is the right atrium. Obviously, there's a valve which is called the tricuspid between the right atrium and the right ventricle, and the mitral valve is between the left atrium and the left ventricle. Since we are talking about total anomalous pulmonary venous drainage, we are interested in the veins that normally come to the left atrium. We have 4 pulmonary veins that come to the left or right side of the left atrium, and the other 2 to the left side of the left atrium. And hence, these are the pulmonary veins. These are the left side and these are the right side. They come to the left atrium after being oxygenated from the lung. This is normal. So when we call total anomalous pulmonary venous drainage, that means these whole 4 veins, they are no more coming to the left-sided atrium. Their blood flow is now being delivered to the right side. And since they are veins, they can only go to areas which are venous or low pressure like them. So imagine with me, where can they go? We can have the 4 veins going directly to the left atrium. That's a possibility, although not the most common.